So why don't we go ahead and get started? I think we've got about this, we have the same number as when you asked that question just a moment ago.
Okay,
Is that okay by you?
that is great. And so you can see the slides and you just tell me when you want me to go to the next one, okay?
Yes. So welcome everybody. I know that my square says that I am Paul Gross. I'm filling in for Paul Gross tonight. And I'm Michelle Schusterman. I'm the co-founder of the CP Research Network, for those of you who don't know me. Tonight, we have a webinar that is actually one of my favorite topics, and it's going to be on learning health networks. And for those of you who don't know yet, the CP Research Network is actually a learning health network. So we're going to learn a little bit more about what that means, or a lot more. And for those of you who have not joined us before, we have this MyCP webinar series that we host regularly. And these are presentations for the community, and we have discussions about the network and the work that we are doing. Tonight, we are joined by Amy Bales. She's a physical therapist, and she's at Cincinnati Children's Hospital. And she also has a very special role within the network. She's in charge of our quality improvement. So we're going to learn about that term. What does quality improvement mean? And as far as the Learning Health Network goes and that terminology, we're going to find out why and how this is one of the primary mechanisms for changing care and treatment for our community. Next slide, please, Amy.
Oops. I failed you, didn't I?
No, you didn't.
Here we go. Okay.
So first, I'm going to give us an overview of the CP Research Network. Some of you have heard this before. It's not going to take me very long, but it'll serve as an introduction to those of you who perhaps have not joined us in the past for other MyCP webinars. And then Amy is going to give, or Dr. Bales, I should say, will give a presentation on learning health networks, and we'll have our Q&A. Next slide. Okay, so back in January, we had 4 web properties or entities that merged together to form the new Cerebral Palsy Research Network. I had CP Now, which was a nonprofit 501c3. We had MyCP, CP Daily Living, which was a blog that I used to maintain and how I got started actually doing work in the community. And we had CPRN. Next slide. So all of these properties came together, and we came up with a very similar but slightly different mission that merged all of the activities that we were doing separately. So we are focused on optimizing the lifelong health and wellness of people with cerebral palsy and their families. And we're going to do this by focusing on high quality research, education, and community programming. Next slide, Amy. So what is the CP Research Network? For those of you who don't know, we are now a 501c3. The original CPRN, or CP Research Network, was not a nonprofit. So now it has a nonprofit status, and it organizes a network of institutions such as hospitals, clinicians, therapists, researchers, and patient advocates, all working together to improve outcomes for people with CP. It also includes what's called the DCC, or a Data Coordinating Center, at the University of Utah's Population Health Sciences Department. What does that mean? That means that the data or information that is being collected, whether you participate in our community registry through MyCP, or if you happen to be part of the clinical registry, which is the clinical registry is the mechanism by which we are getting information when individuals with CP go to a participating hospital or clinic that's part of our network. All of those data points go to what's called the Data Coordinating Center. The CP Research Network, I just mentioned, is comprised of clinical and community registries. Our community registry, I will point out, That is self-reported information. So when you sign up for MyCP and you take surveys and you answer questions, that's information you're reporting to us about your experience with CP. We also now, after our merger, have a focus on education and well-being programming. And most recently, we started an adaptive fitness program with Staying Driven, and that's being held for free twice a week. So that's a very exciting update. Okay, next slide. Oh, same slide, next slide. So MyCP, I just told you quite a bit about that. We want to encourage people to join us, whether you're a clinician or individual. Clinicians can participate in our discussion forum. Individuals with CP or their caregivers can participate in the registry itself. And we also offer tools, information to support your care experience. So there's different tools that we are adding to the portal or to MyCP, and you can learn more about your individual. When you give us your information about your experience with CP, we are able to then create a profile and provide information that helps enhance your care. So you can sign up at cprn.org/join MyCP. Next slide. Okay, this is the kind of slide that Paul Gross really enjoys because it's got lots of data on it. And this is an overview of the people that make up our registries. So we have what's called patients per GMFCS classification in the CPRN registry. That is a profile of patients by GMFCS. So if you're not familiar with that terminology, that's an illustration or classification of someone's ability to move around in their community. Are they a wheelchair user? Are they ambulatory? How much support do they need? And it looks like it's a 5-level scale, and we've got level 1 and level 5 as being the two most prominent profiles in the registry. The MyCP members that we have and the people that comprise that, we've got the majority of them are individuals or caregivers of people with CP, and then we have some advocates and providers in there as well. And there's, I think, now 1,235 or thereabouts.
Wow.
So that's just a little bit of information of who participates in the community registry. And I believe the left side is the clinical registry. Am I correct about that, Amy?
Yes.
Okay. The CP Research Network programs. So, pardon me. We are focused on engaging the community. We want people to participate. We want a diversity of people to come to the table, whether it's virtual or in person, and to share your experiences, your insight, what you would like to see for the community, what kind of research you think is important or missing. With that said, we are focused on research and quality, which Dr. Bales is going to talk about tonight. We're focused on education, and we have tangible resources such as the CP Toolkit and the Caregiver Wellbeing Guide. And then our health and wellbeing programming and MyCP. These are the areas that comprise the CP Research Network of today and what we are focusing our energy on to move the community ahead. Next slide. So where do we have members of the CP Research Network? The green pins are sites, they're hospitals that are enrolling patients currently. The yellow pins are preparing registry. They're preparing to enter the registry. The red is they're still working out some of their compliance issues. There's a lot of pieces involved with becoming a member of the network. So it requires the coordination of a few different entities within a hospital. And then the blue pins are candidate sites, are sites that have expressed interest in becoming part of the network. And you can see that there's a really nice distribution all over the United States. And I believe we have one in Canada. Next slide. This is the CP Research Network study pipeline. And this is an illustration of studies that have been undertaken so far and quality improvement. And I should make that distinction, Amy, because you're going to get to that tonight, the difference between a research and quality improvement study. We have on the left-hand side, ideas that are being submitted to the research network for review and consideration. And then moving further along, all the way from study execution, preparing a manuscript, and then the actual publications. So we've got quite a few manuscripts right now that are getting ready to be published. Yes. Oh,
Bless you.
Okay, next slide. Now I'm going to turn things over to Amy Bales, who is our primary host for this evening. She is a physical therapist 3. What does that mean, Amy?
It just means I'm not a physical therapist 1 or 2. I've been there a long time.
Okay. Amy's a very—
and I have a lot of years of experience.
Amy's a very tenured physical therapist at Cincinnati Children's Hospital. She's an associate professor and she's at the UC Department of Rehabilitation, Exercise and Nutrition Sciences. She is the task force leader and CP registry elements for physical therapy. And that CP registry elements, for those of you who don't know, that refers to those data points. How do we come up with that? Well, we have people like Amy that are working to help identify what points are important or what pieces of information are important to collect for us to study further. Amy is a member of the CP Research Network Steering Committee, and she has the incredible role of being our network quality improvement leader. Amy, welcome.
Thank you, Michelle, for your introduction. It is such a pleasure to be here and talk with you tonight. I am very grateful for the opportunity to be part of the CP Research Network. The background that I bring to you tonight is my training in quality improvement methods that I did obtain at a 6-month training course here at Cincinnati Children's. So tonight our objectives are to describe what a learning health network is, like Michelle said. We're going to talk about how learning health networks function and how they can improve outcomes. We're going to talk about the current status of the CP Research Network as a learning health network and discuss in particular the quality improvement projects related to this effort and understand how you can get involved and share ways of helping us move this forward. So first, what is a learning health network? Well, a learning health network is actually, like Michelle said at the beginning, a group of institutions and stakeholders that could be anybody: clinicians, patients, caregivers, insurance coverers, providers, hospital administrators that align and collaborate around a common goal of improving health outcomes for some people with a particular condition. So in our case, it's cerebral palsy. There is a lot of team collaboration, absolutely essential. And we promote collaboration by standardizing processes, sharing information, and not recreating the wheel. And also in a learning health network, participants observe their own results and we learn from the experience of others. So if it's a group of institutions, I'm going to learn from, I'm going to get to see how my institution's doing, but I'm also going to learn from Aloysia's institution what worked for her. So we're going to share things. A learning health network harnesses the collective experience and motivation of all of the engaged stakeholders with a lot of communication and a lot of co-production, meaning that all stakeholders are involved in all parts and all processes of the learning health network. That's very, very important. Like I said, we're going to share best practices, what worked at your institution, what didn't. We're going to share data. We're going to apply quality improvement methods, which are a little different than strict research methods that you may or may not be more familiar with. We will engage in research, though, to improve outcomes. And a clinical registry is very often at the heart of a learning health network. In our case, also, we have a community registry like Michelle referred to when describing my CP. So some examples of learning health networks that I wanted to tell you about in relation or specific to other pediatric conditions, the sort of very original one that is often talked about because they've demonstrated great improvement in outcomes for these children that have Crohn's disease and inflammatory bowel disease. And that one is called Improve Care Now. There is also a National Pediatric Cardiology Network, a Rheumatology Care and Outcomes Improvement Network, a Renal Outcomes Collaborative, a Sickle Cell Treatment and Outcomes Research in the Midwest, the Autism Learning Network, and Cystic Fibrosis. There are more. These are just the ones I chose to share with you. And I really hope that by seeing these, that this lights the fire under you and that you feel compelled to talk to other families about advocating for support and involvement in the Cerebral Palsy Research Network, because these have already demonstrated how these networks can improve care. They all have a catchy little logo, and I put those on the bottom here for you too. So at the heart of all learning health networks are sort of common structures and components, and those are that there's a system of leadership that's defined. So there's people on certain teams like the steering committee and those types of things. We have a governance and a management structure. We do quality improvement. We engage the community. We use data and analytics to learn from our information, and we do research. So those are 6 components of all learning health networks. And what some learning health networks do is they're becoming a learning health network because it can take several years to become a mature and productive learning health network, is they have suggested that you kind of grade yourself every year or so to see how you're doing. And on this pretty little spider web that you see on the slide here is just a recent depiction of how some of the CPRN leaders came together in last fall to kind of score ourselves on how we're doing in these components to see where we really need to work on improving or where we're doing well. And these scores range from a 1 to where we wouldn't have started in that area at all to 5 would be the most mature or the best that we could be in that area. And as you can see, we're in the 2s and 3s, which seems to be comparable to some of those other networks I told you about when they were in their developing years. So today we're going to talk really about quality improvement and explain what we're doing in that regard. Quality improvement is also referred to as QI. Okay, so what is quality improvement? Well, quality improvement is this big push in healthcare defined by the Institute of Medicine that we really should be monitoring and improving care in these following areas. Care should be safe. Care should be effective. It should be patient-centered. It should be timely. It should be efficient, and it should be equitable. So these are the areas that that are very important to monitor and to improve care in order to be a reliable health provider. How is quality improvement different than research? And this is a really good thing to think about, and feel free to either chime in with questions or save till the end, either one. We'll have time at the end. So in research, which people are more familiar with, we're testing a hypothesis. Like, I think that cranberry juice will improve my hearing. So we're going to test our hearing before we drink cranberry juice and test a whole bunch of other people and do that sort of thing. Whereas quality improvement, you're really assessing a process or a program or a system. And we'll talk more about that in a little bit. In research, when you're a participant in a research study, the information that's going to be gained probably isn't going to benefit you, the participant in that study. It might benefit people in the future that are coming down the pike for care as we learn what works and develops programs for that. But in quality improvement, that knowledge that we're learning as we're assessing and improving the process, program, or system, those patients and clinicians working in that system will benefit from it directly. So in a research study, there may be some risk to the study participants. For example, if you agree to be in a research study and you're getting an experimental treatment, there are maybe some risks depending on what that treatment is. Some might be high risk if you're getting snake venom to cure something, right? In quality improvement, there is no increased burden for participants because it's your regular care. You're getting care. Research is designed to answer a specific question, where quality improvement is designed to improve a program, process, or system. And another thing about research that's really, really important and very different than quality improvement. And if you've participated in research studies or done research, you know that in a research study, it's very strict. All the data is collected and sort of kept behind a curtain before it's analyzed and before we can determine the benefits. Whereas in quality improvement, it's ongoing and we're constantly looking at the information to see if we got improvement in what we wanted to improve. So it's iterative and it's happening all the time. It's not, we don't collect all this information and then save it to analyze later. We're constantly looking to see if what we're doing is improving whatever it is we're trying to improve. So let me give you some examples of what a learning health network can and has accomplished in some of these networks I've described. So in the Improve Care Now one that takes care of, the goal is to improve care for children with inflammatory bowel disease or Crohn's disease. They instituted pre-visit planning in all the clinics, and they didn't start with all the centers. They started with a few of the institutions, and they organized, they came up with an idea to standardize the process for pre-visit planning. So before you get to your appointment, they already know what your symptoms have been. They know some other things about you so that they can hone in on certain things and track certain things. And by doing this, they were able to improve the remission rates in these children significantly. And I don't know the exact numbers off the top of my head, but there are more children in remission with these inflammatory bowel diseases than there's ever been. And it's making it hard for centers that aren't part of the network to justify not doing what they're doing because it's really improving the quality of life in these children. So another example of what a learning health network can do, on the right, there's a project, and these are all things that have been published. So I just put the titles up here, but you can look up any of these networks and learn more about them. There is a renal outcomes collaborative for children with renal transplants. And one of the things that they noticed, and this might come as a surprise to people, but when children were coming for their appointments, the blood pressures were not being measured in the same way at all the appointments and by the people measuring. So it was not a very reliable measure. And getting a good blood pressure measurement after a renal transplant is a very smart indication of how things are functioning, how your new transplant is functioning. So that might seem like oh my gosh, but this really is able to, kind of like starting at the very beginning with Julie Andrews. Let's get the blood pressure measured correctly, right? So that's one example. And then on the bottom left, the Autism Network is one of the newer networks, and they're collecting data from visits. And in this particular publication, they're just describing the quality of life of children with autism in their network. So they didn't improve care yet, but they're able to describe a large population of people that they've never been able to do before in order to move the field forward in perhaps changing care to demonstrate an improvement in quality of life later on down the road. And then on the bottom right is an example of the idiopathic arthritis network, developing some shared decision-making tools that they tested through the network that they have. So those are just some of the really cool things that are out there, but there's many, many more examples. So today, like I said, we're going to talk about our quality improvement efforts, and there are so many things we could do to improve it. We have to start somewhere, and we're not going to wait for just the right time. We're going to go out and we're going to start it. And one of the things that people like to do, especially people in healthcare, is we need to have all the ducks in a row and everything lined up just right, because that's how we all have functioned for so long before we want to like change something and see if it makes a difference. Well, that's not how we're going to do this. We're not going to wait until all the stars align. We're just going to start doing things and measuring things and seeing if we can get certain things to improve. So let me tell you what we where we're starting. So all these ideas came from input from stakeholders, including researchers, clinicians, caregivers, families, and healthcare leaders that were taking care or involved with or committed to improving care of those with cerebral palsy. And these are the 4 that we're focusing on right now. The first one, and the one that's furthest along, is reducing baclofen pump infections, which is a big problem. And we have 2 things that we're doing right now, 2 sort of processes or things that we're measuring or looking to improve. One is we're trying to standardize using a certain protocol in the operating room. When the surgeon is doing any baclofen pump surgery, we have certain steps that we want them to follow. Did you do this? Did you use this in the surgery? Did you do that? Now, I don't do those surgeries, but I look at the forms a lot. And then the other thing that we're doing is we're tracking or monitoring or reporting out infections that happen from each of these baclofen pump procedures. So any procedure that's done, we're just tracking it and we're adding up the infections that happen along the way. So those are 2 things we're measuring that we hope will result in a reduction in baclofen pump infections. And we've done that across 4 centers that are participating. We just had a 5th join, and now we're ready to ask other centers. Now that we've demonstrated sort of what's working, we're now ready to involve more centers in doing that. The next topic that we're looking to improve on is we would like to reduce pain in adults with CP, because it's reported to be pretty high in adults with CP. But the first process or system that we're going to be monitoring is increasing the number of adults with CP that are screened for chronic pain when they go to see their provider. And kind of like that it's the end of the day, blood pressure measurement, right? You would think that you go to the doctor, they ask you if you have pain. But we're finding that not all the centers are screening their adults for chronic pain. And chronic pain is defined as greater than 3 months. So that's where we're starting with pain, improving or reducing the pain in adults. The next one is improving hip health, and we are starting with improving the hip surveillance for children that are non-ambulatory or GMFCS levels 4 and 5, like Michelle talked about, those functional mobility levels. And that is in a specific age range of children that are between 3 and 12. And the reason we are doing that is because there are guidelines through the American Academy of Cerebral Palsy and Developmental Medicine. So hip health is a big, big field, but we're going to start in this one area. Now, over time, what we hope is that in these areas, we have a portfolio or several projects related to improving hip health. This one in particular is for kids that are not walking, but we might have others in the future. And then the last one that we're focusing on right now is improving care and outcomes for those with dystonia. So dystonia is a type of movement disorder where it's characterized by involuntary movements that can be quite painful and interfere a lot with function. So it's not well assessed or screened for or evaluated. So we're working on improving, increasing the number of children that are assessed for dystonia. Again, like that blood pressure measurement, we're sort of starting at the very beginning, but we hope to, over time, be able to expand those efforts.
Amy?
Yes.
Can you go back a minute?
Of course, tell me what to, you want me to go back
I
on
wanted
slides?
to feed, just one slide, back to your
Okay,
previous slide.
sure.
I just wanted to give people an idea. So let's say you find that there is one site where they are having no infections. I'm just making this up from their baclofen pump surgeries. What would you then do if you're looking at like that site is performing better than the other sites? How would you proceed in moving the information forward and determining what's happening?
Well, I mean, the nice thing about these groups, and Michelle showed the map of all the place centers, like not all centers are participating in all of these efforts right now. So like I said, baclofen pump is 4 centers. So if one center is saying, well, we don't have that problem, then we share ideas. Well, what are you doing? For example, one group, this came up in one of the other topics, hip health. So a lot of this is done manually by looking at charts, or sometimes it can become electronic depending on the resources available to you at your center. But one center was like, I can't even identify from the charts who the children are that would be non-ambulatory or GMFCS 4 and 5. So we're saying, other centers are saying, okay, I have a certain these centers are an epic smart phrases, or not smart phrases, but flow sheet things that we use to get that information in our record. And you need to talk to your epic people, and you can go into this community library and download that. So this, you can build your system the way we've sort of built it and see if it works for you. So those are some of the things we do. So we don't say you're not in the project. Partially because anything like pump infections, you're not just measuring it once, you're doing it over time. So every month, every quarter, every year, some things we measure every week. So it's not like research where you look at it and then you're done, it's ongoing.
And can you give an example of an aha, another one where there?
So the big, so again, I think a big aha is that we it's humbling, and I think that as providers, we're not always doing what we think we're doing. So we're not always screening for pain in the adults, or we're not always assessing for dystonia in the way that the evidence or the literature or recommendations say we should be. So I don't know if those are the ahas that you're looking for, but that's the stage we're at.
Paul Gross wants to share something.
That's you. The real Paul Gross?
He's found another way in here.
Ah, get him out. No.
Okay. So hi, Amy and Michelle, you guys are doing a great job. I just heard the sort of example of an aha. So the Hydrocephalus Clinical Research Network, that is a learning health network like this, had a very similar protocol to the baclofen pump infection protocol for shunts, which is the primary way kids with hydrocephalus are treated. And so when they ran the protocol for a year, what they discovered was if the surgeon if the surgeon used a pump hand scrub instead of doing a traditional scrub with a sponge, the patient was 4.5 times more likely to get an infection. So by doing this over like 1,000 or 2,000 patients, they were able to figure out exactly one thing that was actually a factor that would make more kids get infections. They also found out that if someone skipped 2 or more steps in the protocol, they were, I forget what they were, like a standard, I can't remember the exact percentage, but they were significantly more likely to get an infection. And so there are big ahas that come from doing this type of thing over a lot of patients.
Mm-hmm. Good example.
Thank you, Paul.
Thank you, Paul, for sharing that. Anybody else have questions for this right now, or should I continue? We're almost done with the formal slide part, so I'll go to the next slide then. So there's a few ways we would like to encourage you to get involved for those of you that may not be involved, and that is to go to cprn.org and learn what the network has to offer. And this is just a picture of the screen when you go to that. And then, you know, next time you go to one of your doctor's appointments, find out if your center is part of the network, and you know, ask them to look into it. We would love for you to join MyCP and participate in the online surveys and the discussions, and contribute to all of us learning how to improve care. And then I did put up here on this slide, just if you're really interested more specifically in quality improvement, this is a great short YouTube video that really breaks it down into really easy terms as to what quality improvement is, in case you're interested. And that organization that has that video, they have many videos, but I am, you know, if you like that one, you can look up some more when you see that one. We have a community advisory committee as part of the network. We'd love to have you participate in that. And if you have some other special interests or talents that we didn't talk about that you think might be useful, we'd love to know about those as well. We like to have community stakeholders on all of our improvement teams, in any area that you're interested in. So we hope that you will spread the word and get excited about doing this kind of work with us.
And we have had, I want to encourage all of you not to be shy with your providers. We have had sites that have joined the network because an individual with cerebral palsy or their caregiver has advocated for that to happen. And if any of you are interested in participating further in our work, you can contact me or Paul. My email is Michelle. I have one L in Michelle at cprn.org, or Paul at cprn.org. So we would love to have everybody's experiences reflected in the work that we're doing. That's what we're all about.
And I think, you know, I really agree with Michelle's point that if you are a family member or caregiver or someone with CP and you go to your center, your voice speaks so much greater than a healthcare professional working at that institution. It really does. And it should. If it doesn't, you know, that's another problem. But I think that when I look at these other networks and what they're doing, and the fact that you know, some centers are hesitant to participate for CP, that is just not acceptable. So anyway.
Thank you, Amy, for saying that.
So now that's the end of our formal presentation. We'd love to hear your thoughts and questions. And maybe there's something we didn't cover you want to know about. We're happy to answer those too, in the chat or unmute, whatever works.
I think
Hi there, this is June Kales. Are these networks similar to learning collaboratives in healthcare? And what are some of the challenges in terms of course corrections, or what's not work, what needs work?
So the first question, yes, learning collaborative is another term that you might see to describe a learning health network. Also, a learning health system would be another term. And the way I've chosen to understand the differences based on what I've read is that a learning health system might be one healthcare center, whereas a network would be many centers. A collaborative would also be many. And can you repeat the second part of your question? I didn't quite understand that.
Okay, so for these networks, what have been the challenges in terms of what might need work, what might need improvement? What are some of the lessons to apply in that area?
So do you mean what are some of the what are some of the challenges in a network, or what are some of the problems that we think we should improve on in care?
The actual challenges of running the network itself.
Great question. Great question. Well, you know, I bet that Michelle, Paul, and I could all speak to that. I guess I'll start, but feel free to chime in. One of the reasons we did that thing where we did that little spider web thing is we wanted to see how we're doing, because it's really hard to rein in a lot of institutions, a lot of different providers, a lot of different stakeholders to having a common goal. I think the biggest problem in getting started is that, you know, a lot of us started doing this work outside of our 9 to 5 or 8 to 6 job. So, and I think that is probably, you know, that takes a while to build things. But it's important to get people that are really passionate about it. And you can see by the number of hours and number of people that have been involved in this, that is what we have, is a really good group of people. There's some other issues, you know, other challenges. Everybody's got different ideas and that sort of thing, but also that is the exciting thing, and how you get innovation and how you get people to brainstorm trying different things. Michelle or Paul, what would you say?
Well, something that does come up a lot, and a question I had early on, is what happens when it comes to an institution feeling some vulnerability about exposing weaknesses they have along the way, you know, where they're not rating as well as other institutions. When you're looking at a certain process like baclofen pumps, what if one of the sites has a large number of infections, and that information is now public?
Trust.
Yeah, I would go ahead.
Nope, you go ahead, Paul.
I was going to add that from where I sit, there are a couple big challenges. I think one of the challenges, now that we're sort of 5 years, almost 6 years into this, is we get clinicians that are very excited, and sometimes it's whole clinical teams, the multidiscipline teams that treat CP. But our ask is that they, as Amy said, they find extra time, and as it turns out, some of this work contributes to their maintenance of certification, which is great. So it's kind of a core thing they'll have to do. But there's really a lot of extra time to do research or to participate in quality improvement, and clinicians are super busy. And so there's a time commitment, and we're asking them to do things that are outside of their comfort zone. Fundamentally, we're asking them, A, to get in touch with their IT people and change the way their electronic medical record works. And that process takes time, and they don't really know anything about that. They just know that it's important, and so they try to find the right people and get the right support for that. A second thing is, once that system gets implemented, it's a set of forms or flow sheets that Amy was referring to that they're interacting with on the computer when they're interacting with a patient. That's change of practice for them. And changing, you know this for human nature. Anything where you're changing practice, especially for anything that's well grooved with a clinician, that takes, or a medical system, that takes time. So there's just things, there are inherent things that sort of can slow this down. That said, I feel quite proud of where we are after 6 years of work at this, you know, with over 5,000 patients in the registry, and these, 4 significant projects going, and the 30 sites that have done the hard work to get on board. So I feel good about where we are, but there are certainly multiple challenges.
I think one more challenge that I would mention that's unique to cerebral palsy is that there's many disciplines that take care of individuals with CP, and that's different than some of these other conditions. I suppose autism might be similar. So we have to engage the neurosurgeons at the institution, the orthopedists, the rehab doctors, the therapists. So it's what makes our field very rich and exciting. But that can be, I think that has been something that's been hard for us to get everybody. Some institutions, some of those providers are more engaged than others.
It looks like we have a few questions in the chat. Paul Stanches asked if there was a quantitative measure for chronic pain. So see if we can move to that. Would that be okay?
Yeah, there are measures for pain. We are not going that deep into it yet. because that would involve a larger change of practice. We're starting at the very beginning. Did you even ask if they had pain that lasted more than 3 months? And then you asked other questions about, did it interfere with daily living or function? So we are using questions that are on some other standardized surveys about chronic pain, but not the whole measure itself. And I don't know the names of the whole measure itself off the top of my head. I have to think about that. Paul, you had your hand raised too. Did that help answer that question?
Yeah, I also have a question about, so I'm 60 years old, 61 years old, pretty functional. And I've never gone to, well, at least not for 50 some years, to any particular center. I have my healthcare providers that I have assembled myself, so to speak, over the years to help with overall care. Is there any benefit to the research network for me to share information with the clinic?
We would love to hear about your experiences and through my CP.
Okay.
You know, the fact that you're, yeah.
I have participated in a number of these studies.
Michelle, would you answer that question any differently, or Paul?
As far as, I was unclear, Paul Stanches, if you were saying whether there was a benefit to bringing information that we discover from the network, or if you were saying you wanted to bring your experience in visiting your clinic to us.
Yeah, so I guess because I don't go to a center per se, I see individual providers. Other than contributing through the research network questionnaires, is there any way to provide additional input to the research network, I guess?
Yes.
I'll answer. Oh, go ahead, Michelle. Sorry.
No, you go ahead, Mr. Paul.
Okay, so one of the efforts that we've got going on is an effort to understand what we're actually preparing a survey that's specifically about how adults think about their care and how knowledgeable are their primary care providers about CP. Do they have any training? And in particular, are adults with CP aware of additional non-direct CP related but indirect CP related health conditions like metabolic and cardiac risk as a function of having CP, and therefore making sure you're seeing a provider that's knowledgeable is really important. So there's a couple places where you could participate in discussions, and we would love to hear about your experience with healthcare and how knowledgeable people were and the kinds of issues you seek out and whatnot. So yes, that would be very useful both interactively, and there's some specific places for you to engage in that.
Yeah, because I would agree that that's one of the biggest gaps, especially if you're mostly functional, that many primary providers aren't very knowledgeable about the different specialties. In fact, anecdote I always tell it, I actually found out about physiatrists at 55 years old by Googling, looking for a physiatrist, what somebody that did something around physical medicine.
Yeah.
So yeah, I mean, yeah, I would definitely. I'm sorry. How did you say I would participate with that information?
Well, so you should start out just send me a mail and say I'm interested in participating. We've got a couple sort of small groups that are discussing this, led by a pediatric and adult physiatrist named Dr. Ed Hurwitz, who did our webinar back in December. And it's a very interesting area. We're exploring ways to get more, increase capacity in the ability to care for adults with CP.
Okay, I'll email you guys.
Thank you, Paul.
Okay.
And Paul.
Sorry, this is Lori. I had a question that sort of piggybacks on Paul Stanches's question. I've been aware of this for a little bit through Mary Gennady and a few others from the APTA and the Pediatric Academy. I know I don't work with the clinic either. Well, actually, I'm retired from a university, but I do work with state agencies, and I'm kind of not aware that actual like developmental disability state agencies are they part of a network, or could they be? And as I'm sitting here thinking, you know, I work with some other clinicians, but we're all consulting through the developmental disability state services project, if that makes some sense. So how to connect that group outside of doing it just on my own with the little sort of a private clinic. It's not a real clinic. It's just a bunch of us together working for DDS, basically. Do you have something
Great
similar
question.
in other states? Yeah.
Great question. Great question.
And I have a lot of folks that I serve who would be willing to be involved in my CP, who I've actually kind of encouraged, and they've done some surveys and such to involve them.
Well, if they don't go, if they're, I mean, we would love for people to be involved in different groups and committees, even if they do not go to an institution that's part of the network where their data is being contributed from their visits to their providers. So we don't have any DDS agencies that are part of the network where they're contributing information from that person's visit to that provider.
I guess the reason it occurred to me, because that DDS system is the most consistent system they have. They may go to a PCP, but as adults especially, many of them do not in the rural parts of Oklahoma. Don't go, they're lucky to get a PCP, period.
Right. That is a really interesting point. We'll have to think about that. That's a,
Anyway,
but
okay.
Again, we would love to have people involved in different groups. You know, if they want to be part of a committee and offer their insight into different topics as we develop efforts in different areas, that would be terrific. Even if they're not going to a center that's contributing data. Again, I don't know. I'll certainly, I don't know. I'm going to ask some other networks what they do about if they involve agencies like that, where people are getting care and services.
Comes down to what is the definition of a center is
Right,
kind of my thing.
exactly.
We are
Yeah.
really not, we're not that, but we are the most consistent service for those folks. So anyway, thank you.
Yeah.
Thank you.
Really
Thank you for
good
bringing
question.
that up.
Really good question.
I don't know that we have a mechanism for making that happen at this
I'm
time.
going to ask our network autism people. They might have,
Yeah.
this might have come up
Good
with them
idea.
too. Yeah.
Yeah, Amy, this is Christy in Seattle. I think that would be a great resource because there's a
Yeah.
lot of states in the United States that don't have regional centers. Like
Yeah.
the North and South Dakota, Wyoming, you know, they may not have a regional
hospital with a
pediatric care
CP
center
clinic,
or
yeah.
a center that's treating. So to be able to capture the life experiences of those states where there are maybe not population-wise as many people, but their experiences is we want to capture it, and that can inform our care
Definitely.
across lifespan. So it would be great if we could figure out a way
Yeah.
to make that happen.
We'll think about that. Lorraine,
So
I see
what
you
I-
had a question about dystonia, just for children under 18. It actually is from 3 up. So it's not just children. Sorry, Paul. Go ahead.
No, that's okay. I was just going to say, Amy, you should explore with the other networks, but I would also say we're open to having a discussion with anybody that's interested in engaging with us. We're interested in having a discussion. You know, I don't think there's anything rigid about a center definition. I think there are things that we require that, you know, may or may not be possible, but there's all sorts of ways to be involved in the work of the network. And I would encourage you to approach us about your interest in what you're hearing that we're saying and talk about it.
Great.
I think David had a question in the chat a while back about pain. Let's see
Are we
here.
breaking the adults into various groups? That is a good question because we did think about different things. The way we originally were going 18 to 65, the age group, and some people are saying we should just do 18 and older. And then we may, once we're very at the beginning phases of this, We will then maybe break it into different groups, like you're saying, like 18 to 35, 35 to 65, over 65. So that's where it stands now.
Right.
We are just at 9 o'clock, so.
Oh, I think there's one more comment here, but
Hi, this is Poonam.
Hi, Poonam.
So I think from a parent perspective, I think it'll be great if we can have a resource of practitioners in different areas that affect people with CP.
Yes.
And a lot of, and along the lines of what Lorraine was saying, like there's the CDSA, which is in our area, it used to be called CDSA back in the day. So like that, we kind of go to not like these big centers, we may be going to like small providers, so those kind of fall through the cracks and you never kind of can reach those people, but there may be a lot of people going to such providers. So I think it'll be good to kind of figure out a way to capture like how you already have gotten it from Lorraine about the state agencies, but also other private practitioners that are not part of a larger network or like a
Yes.
center.
I think that's a great idea. And if your experience is with a different set of providers or a different setting, have them contact us if they're interested, Poonam.
Yeah, if we can figure out a way to make it less onerous on them, and I think someone else brought up, I can't remember who brought up this point, that we are already like they are short on time and then we are adding more on their plate. So how do we kind of have to be a little creative, and I'm sure this is like a massive task. What you've done so far is phenomenal, but just to kind of think from kind of be in their shoes and think, okay, how can we make it easy on them?
I don't know that the implementation for a smaller setting would be so challenging from that point of view. I think didn't we have some smaller clinics that were involved, Amy? Or was that?
I mean, I think there's pros and cons to both. My experience working just in PT, trying to do something across centers versus private clinics, sometimes it is a little bit easier to get business agreements and things like that from a smaller clinic. But I think it just depends on the volume of patients seen. I mean, it just varies so much. But I do think that again, if you are the customer of any of these centers or clinics, that I can't go to my people any more than I go to, but if you are a customer getting care at these clinics, you need to start asking and asking again and knocking on more doors and asking some more.
And we're willing to have
you
those
deserve it. Yeah.
Okay.
And I think that I think it would also help if we get these smaller providers involved. I think it would also help them learn more about CP, because they may be like, we go to a pediatrician still, even though my son is an adult now. But the number of people with CP that the provider sees is very relatively small. So they don't know as much about CP, but if they got involved in some of this, they might learn more and kind of help. It would help both ways.
True.
Sure, absolutely. I think we can do one more. I want to be respectful of everyone's time. Amber, you have your hand raised. You want to?
Yeah, I was just going to say, don't you think it's also just about educating the center or the clinic or no matter how big or small it is, I think it's just about educating and then, showing them our passion. And then I think if they can understand that, then they become passionate about it and want to engage in it as well.
I think you're right. I think that it's a balancing act, but certainly it's very compelling when a patient or caregiver is bringing forward an idea like this and saying, we want to see you be a part of this network. Will you have a conversation with them? It carries power, and more than people might think. Okay, I think we're going to end there. And then if anybody has questions, you can contact, Amy has her email up here. You can contact me, or you can contact Paul, and I'm losing my ability to articulate myself, so I apologize. Thank you, Amy, for being with us tonight.
Thank you. It's so nice to meet you all.
For sharing your wisdom and expertise. And thank you all for joining us. We really appreciate it.
Have a wonderful evening.
Bye.
Thank you.
Thank you.
Thank you. Thank you.